So it's my pleasure to talk to everyone today about the collaboration of nursing and dentistry, and this presentation is titled The Oral Systemic Health Connection in Primary Care. I am Madeline Lloyd. I'm a registered nurse and also a family nurse practitioner and a psychiatric nurse practitioner, and I am the practice director of our NYU College of Nursing faculty practice, and it's my pleasure today to speak to you. This is a module that is going to be online and available through the CNY GEC, and it was developed by the Hartford Institute for Geriatric Nursing, which is in association with New York University College of Nursing. The GNY GEC is a consortium for 4 academic partners committed to training a wide range of health and human service professionals and interdisciplinary faculty throughout New York State. The objectives of this module is firstly to describe the collaboration between New York University Colleges of Nursing and Dentistry, recognize potential oral systemic health partnerships and new models of healthcare, and finally, to identify strategies for improving oral systemic outcomes for all patients. Let's start at the beginning. The Surgeon General's report in 2000 was really the initial stimulus for the healthcare professionals to start to think about the mouth as really being more of a mirror for general health and well-being. Oral health is definitely integral to overall health, and to come up with safe and effective disease prevention measures was the challenge, because as we know, everybody can adopt to improving oral health and prevent disease. So our beginning started back in 2005, and it was a unique partnership that was formed between our 2 former deans, the Dean of Nursing, which was Terry Fulmer, and also the Dean for Dentistry at the time was Dr. Michael Alfono. And they really had a vision to how can they create new and innovative clinical practice models that meet the challenges of the Surgeon General's report, but also the challenges to improve the overall patient's oral and systemic health and improve outcomes. Up until then, I think the oral mouth was seen as a separate identity from the rest of the body, but as we'll see later, that they really are connected. So out of that vision, we formulated the New York University faculty practice, and our doors were open in 2006. Our mission was to expand access to primary healthcare services and improve the quality of life for all New Yorkers of all ages. Our vision: we really wanted to improve the quality of life for our patients, not just primary care but also dental. We were unique in the fact that our location for the faculty practice was under the roof of the College of Dentistry. So it was like one-stop shopping. People could come to the same building and at the same day take care of their oral health needs, but also their primary health and medical health needs under the same roof. So collaboratively, we could address common health and oral problems together. What services do we offer at the New York University faculty practice? We offer comprehensive, full scope of care primary care. We are unique. We're one of 250 nationally nurse-managed run health centers. We're all nurse practitioners, and we either are doctorally prepared or currently doing our doctorate. We offer holistic, full scope of care, as I said, practice, and collaborative. We have, obviously, for New York State, we need a collaborative physician, and she's located a few blocks down the road, but does not see patients in our office. We offer full screenings at annual health fairs, and that's in collaboration with nursing students, dental hygiene students as well. And then we are available 24 hours a day and on call 7 days a week to our primary care patients. We also offer medical consultation to dental patients, which I'll be able to highlight a little bit more as we go into case studies a little later. So for those who do not know what a registered nurse practitioner is, a nurse practitioner is someone who is already a registered nurse. You have to be a registered nurse, and you've either completed advanced education and training at the master's, or as I said, most of us are at doctoral level. We have a scope of practice that can include performing annual physicals, comprehensive physicals, and also focused health histories on acute and chronic needs of patients. We can diagnose those chronic, such as hypertension, diabetes, asthma, health problems, but also acute problems, headaches, urinary tract infections, upper respiratory tract infections, and prescribe medications as needed. In New York City, we do have a full scope prescription license. Our emphasis is always on health promotion, age-appropriate health screenings, and disease prevention that is evidence-based. The health of the individual in the context of their family and communities and their health education is essentially important, as we really do practice more of a socio-ecological model. And also knowing that our partners are within the building, we can collaborate with dentistry and really practice what we preach with the oral and systemic health connection. This is some of our flyers and brochures. Some of them are shared. The ones on your right that you're looking at is the prescription to quit, which the dental students can give out to their patients, which is a feeder to our practice. And we also have a common goal, which I'll talk about as far as the cessation of tobacco within our clients. Just to touch briefly a little bit on the College of Nursing and the College of Dentistry, when they partnershiped up, looked at, well, what's our strategic plan? What do we want to do together? How do we enhance not just the clinical component, but the educational and the research component of our strategic plan? So we're looking at building and fostering interpersonal relationships, maintaining an environment for excellence, not just for teaching and research, but also for patient care, and leveraging our partnership among dentistry, nursing, and dental hygiene to improve the quality of life for all New Yorkers. Development of men and women of science through combined research efforts, and then promoting global activity. And we've done a lot of outreach both to Central America together in nursing and dentistry, and also in Africa and Abu Dhabi. So as I said before, our three arms that we partnership and work on together is the education, research, and practice. We cross-teach within the curriculum, both at the clinical chair side, so we have a nurse practitioner in the dental clinics working side by side with dental students and dental hygiene students, and they also work together with health fairs, and we have interprofessional disciplinary faculty teaching. So, for example, nurses teaching dental students and dentists are teaching nurses, both at the undergrad, graduate, and graduate level. With our research, we have done quite a few initiatives, such as the tobacco, looking at how do we provide oral care for homebound patients, particularly with HIV, and looking at some diabetes initiatives, which I will also go into a little bit later. We have shared practice sites, such as where we practice, we actually share space with oral medicine, TMJ, and also special needs. And then we actually, both of colleges have medical vans that are mobile health vans, 40 feet wide, with 2 exam rooms that are able to go out and do full comprehensive scope of practice, both oral and dental care, into the areas where they may not necessarily have access to care, for example, at some of the naturally occurring retirement villages. This is just an example of me at the chair side, if you're wondering who I look like. And this is a patient that is both a dental patient at this time, but this is actually Ben, who is my case study, and he is also a shared patient of ours down at the faculty practice. So how do we get patients to us? We had to sort of think of when patients come into the College of Dentistry, what is their point of entry? What is their point of access? What we learnt was that about 30% of the patients that come to the College of Dentistry for low-cost dental care do not necessarily have any access to medical care, nor do they have, so they're one of the 39 million uninsured in America, nor do they have, they might only use the primary care provider as their dentist. so they don't know where to go for medical care. The reason they're coming is maybe they're in crisis, such as they have a toothache. It's easier to come when your tooth is in pain or falling out, rather than you don't obviously feel that your blood pressure is elevated. So to capture the audience who needs access to primary care, we came up with two questions. The first one is, and the dental students ask this, and the dental faculty in their clinics, do you have a primary medical care provider, either a physician or a nurse practitioner? If so, great, congratulations, we're happy. And the second question was, when was the last time you had a physical exam? And if it was greater than 12 months, then they automatically got a referral to our practice. And this is what the referral sheet looks like. They would tick the dentist would sign, or the dental student or the dental hygiene student would sign and sort of indicate to the patient why they were coming. Was it an acute medical problem? So, for example, patients can be in the chair and have a sore throat, but not necessarily know where to go for that, or the worst cold in their life, or it's flu season and the dentist may now know to give them a flu shot, they can come down to us. And again, the other two, as I said, and then we have a combined mission about smoking cessation. So when we first looked at and combined with the College of Dentistry, one of the common key core competencies was to look at what do we have in common. And obviously one of the major things, national objectives, was from the Healthy People 2020. And that's our overarching goal, so that we have this in common. We want to attain high quality, longer lives for our patients, free of preventable diseases, disability, injury, and permanent death. We want to achieve health equality, eliminate disparities, and improve health to all groups. We also want to create social and physical environments that promote good health for all. And really, it's more about preventative, and that since people really often come to dentists every 6 months for preventative care, they may not necessarily think about coming for medical care. So that was sort of what was our common goal that we worked from. From there, we looked at what the leading causes of death are in the country. And as you know, heart disease is our leading cause of death, followed by cancer and then chronic lower respiratory diseases. What's interesting about all these causes of death, leading causes, are they're caused from tobacco, and then physical inactivity, and then toxic agents. So if you take our leading cause of death, which is tobacco, then the mission became for both of us, this is one goal that both dentistry and nursing could work on, to decrease mortality and morbidity for patients. And really the top 4 causes of death are all tobacco related. So if we could reduce tobacco effectively, then ideally we could reduce also the 4 leading causes of death. In the United States of America, when you look at death rates among children from age 1 to 19, we're really not doing so well. We're just below Portugal. And so that was another challenge. What are we doing wrong? Is one, to have a collaborative model seemed to be much more effective. And patients also want to be treated in a multidisciplinary way. They don't expect to be treated in a silo. So to be able to offer multi-services at once was also great for the patient, and we're hoping also good for the outcomes. When we looked at dental care of patients and who did not receive dental care within the last 12 months due to cost, you can see that over the last decade, it's slowly been increasing. And so access to care because of dental costs has risen. And so that's where the College of Dentistry provides a very important service and really captures patients who not only do they not come for dental care, as I said, but also don't come for medical care. Because of that, we had to come up with a couple of creative ways to reach out to patients that may not be eligible for Medicaid or have enough money to really afford for their medical care and dental care. So we actually, in the College of Nursing faculty practice, offer a sliding scale fee to patients who are above, are eligible 300% above poverty line. And then we also came up with a one-time fee referral from the College of Dentistry to us at a very reduced price for us to be able to help triage them medically so that everybody does have access to care regardless of cost at our faculty practice. So let's talk a little bit about some of our shared clinical interventions. I want to provide some case studies today to highlight how we manage patients in our interdisciplinary collaboration. First, as I said, our largest one was definitely smoking, since that's a leading cause of death for the first top 4 causes. We know that it is the single most preventable cause of death in the United States and causes numerous premature deaths and causes up to 30% of all cancers. Nationally, about 20.6% of adults are currently smoking, greater for men than for women. And what we know in the youth is that nearly all of our first use of cigarettes occurs by 18, with about 88%, and that most people, 99%, have actually tried smoking by 26. And once you start smoking, it is very hard to stop because of the addictive nature. So even though we're actually doing fairly well in New York with reducing youth and young adults, have slowed. So the overall smoking rate is now in New York City is down to 15.5%. And a lot of that has come from public policy. Here we've increased the taxes, we've banned where people can smoke, and things like those interventions actually have been successful. But we've got a long way to go. And what we came up with was, after the 2008 Treating Tobacco Use and Dependency Guidelines came out by the US Public Health Services, we decided to implement a tobacco cessation-wide program that's shared with dentistry and nursing. Let me just review a little bit about the new guidelines that came out. The guidelines say to target all patients, that brief and intensive interventions work, that often tobacco smoking cessation treatments are effective and encourage, unless contraindications or special populations, and there really aren't that many contraindications or special populations. By special populations, it may be someone who hasn't had an acute MI a day or two after, or somebody who's pregnant. There are 7 first-line agents available, and 3 of them are over-the-counter here in New York State. The other 4 are on prescription. We know that combination treatments are much more effective than single, and that the behavioral component of the addiction of tobacco is much more effective than, here, just take this nicotine replacement therapy. The 5 RAs is what the guidelines say we should use. The first is, obviously, everyone should be asked about whether they use. And I think historically people have asked and ticked a box but then moved on. And if there's been a yes, it's like, oh, okay, but then that's nothing. And then the patient's just left to going, oh, I guess it's okay to smoke because they never addressed it. The second is to advise to quit smoking. And maybe we were doing that before. But we certainly were never really looking at the readiness to quit and their personal tobacco-related risks. After looking at the first 5 A's, we then looked at Prochaska's stages of change. And so is the patient in a pre-contemplation stage, a contemplative stage, a preparation? If the patient then is in an action or a maintenance phase, that's where we actually go and do the other 2 A's, and really get in there and try and help the patient and assist them to stop smoking. We use motivational interviewing techniques to help them to assist and arrange for follow-up. One of the assists that we do is to offer nicotine replacement therapy. Why was it important? We've looked at what the data, the evidence showed about the tobacco use treatment in primary care, and interesting enough, 70% of the 45 million smokers who are left in US report that they want to quit. and that about 44% try and quit each year on their own. But we know that cold turkey is only really about 30% effective, that there are actually more effective mechanisms if they use some other nicotine replacement therapy. So 70% of all tobacco users who are in your outpatient clinic would have, with only about half has been receiving treatment and intervention. So as I said, everyone's been asking, but nobody's really been helping them. When we looked at some of the outcome for primary care providers, where obviously, and dentists are considered a primary care provider in this healthcare, that both of us, nursing and dentistry, are in a very important position to really be delivering evidence-based tobacco use treatment. And so we adopted these guidelines into the School of Dentistry and Nursing. The primary care provider needs to screen more effectively, but often we're reluctant because maybe they didn't have the tools and the necessary know-how as to how to help somebody. When we looked at what the nurse practitioner outcome data looked like for providing tobacco, and you think that nurse practitioners would do this well, 80% of the time, again, we were asking about tobacco use and advising patients to quit. However, we were only advising their willingness to stop 26% of the time. We weren't looking at the assess and assist to stop smoking. And dentists and dental hygienes were at 12 and 21%. So we certainly had a lot of room for improvement. So in July 2008, we implemented a multi-component intervention to improve the quality of treatment use in both nursing and dental clinics. We utilized the 5A approach, and we partnershiped with the New York City Department of Health as well as the tobacco cessation groups to implement the program. In our electronic system, we implemented something called eQuits, so we had a reminder electronically, and then also we were able to get 3 of the nicotine replacement therapies at no cost within the clinics. So for example, if you look, what you're looking at here is our flow sheet algorithm that we came up with to address the treatment. And the dental hygiene and dental faculty and dental students were able to give out the patch, the nicotine gum, or the lozenges as the patient was required. So here is about the first 3 A's. We asked about tobacco use, we advised the patient to quit, we assessed their readiness, and if they were ready to quit, was it going to be within the next 4 weeks? If it wasn't going to be in the next 4 weeks, we would tell them some of the harmful effects and the benefits to quitting, and that's where it would stop. Because, as you know, when we use the Pachetsky's changes, they actually have to be in the action phase to be able to quit successfully. So if they were ready to quit, then we would assess their need for either using gum, lozenges, or patches at no cost to the patient. And then they would be also referred down to me for additional behavioral counseling. And if somebody wanted the other four items that were on prescription, that was also an option for them when they came down to the faculty practice. So these are just highlighting the motivational interviewing skills that we use. You know, we're not belligerent them to say you have to stop smoking, but we're sort of talking about how important is it for you to stop smoking and how confident are you that you can stop smoking, and really building on some of these commitments to change and rolling with their resistance to help them achieve their goals. We looked at the 5 R's as well. How relevant is it that they smoke? The risks to them, the long and short term. What are the rewards about quitting? What are the roadblocks? Who is your enabling friends that you may have to say goodbye to, and who are the ones that will be supportive? And then the repetition. You know, if you aren't ready today, I'm going to bring it up every single time you come. And one day you'll be ready, and we know it takes on average about 7 times to quit before someone successfully quits. This is our outcome data from the eQuits program and also from the interventions at the College of Dentistry. So the first slide you're looking at is how much nicotine replacement therapy the dental school was able to give on a month-by-month basis, and was very successful, and the patients were very responsive. And then this is our electronic data. So our practice was one of the EQUIT's top performers, and we went from 53% of intervention rates to 61. Obviously, we've still got improvement, but when we look at where everybody else was, we were actually doing fairly well. So let's talk about our first case study, where I'm going to show you a little bit about how we integrate the smoking cessation program. Estella was a 43-year-old female who was referred to us at the nursing faculty practice by the 7th floor clinic for smoking cessation. She smokes a packet a day for 25 years. Her brand was menthol, and as we know, actually, menthol smokers are more addictive and harder to stop than plain. Her first cigarette was within the first 30 minutes of her morning coffee, which again, if somebody is smoking initially within the first 30 minutes of their morning, it's because they're withdrawing from the night before, and so you know you're dealing with someone who actually is much more highly addictive to the nicotine than not. She's tried to quit, look at that magic number of 7 times previously, and her longest smoke-free period was 1 month. She wasn't interested in using nicotine replacement therapy and wants to try cold turkey. These were the things that we offered, and after really talking to her about why nicotine replacement is important, there's definitely the science and the art here of what we do. We've got a little smarter. If someone is withdrawing from nicotine and becoming angry and cranky and going off cold turkey, they aren't able to focus and work on the behavioral changes that is necessary. So the idea behind nicotine replacement is, let's stop you from withdrawing. Let's give you the one product out of the 400 or 4,000 that is in one cigarette. And if we can just replace the nicotine, stop the withdrawal, you won't be this angry, cranky person and irritable, and you will be able to focus on changing the triggers and the behavior so that you'll have a more successful, hopefully, cessation. The thing with Estella, though, is that she also had never had any primary care, or her last annual physical was 9 years prior. So we were able to, and her second visit, bring her back and say, we can also do your primary health care needs. We looked at her past medical history, her family medical history, her risk factors, age-appropriate screenings, and preventative care. Her physical assessment was noted. She came into the overweight category with a BMI of 29.8. Her waist circumference was greater than 35 inches, and her blood pressure was high. It was a 135/85. That's not normal. And her fasting sugar was elevated at 118. So she was coming in with a little bit of metabolic syndrome and pre-diabetes as well. Her total cholesterol was 234, and we looked at her immunizations, gave her a flu vaccine, and talked to her about well female needs. So you can see that just from screening from tobacco, this patient was able to get both her oral and her systemic needs taken care of. When she was referred, she was also given a diagnosis of periodontal disease. And what we've learned is that when someone has periodontal disease, we really need to think about what is going on within that systemic system. We know that there is inflammation at the gum, and that can translate to inflammation within the bloodstream and be causing other systemic illnesses such as diabetes, hyperlipidemia, putting people at risk for heart attacks. So all I would say to you is, if you see someone with horrible mouth disease or gum disease, their teeth are rotting out, think about what else is going on within that body. It's not just the mouth. So oral manifestations are quite often a reflection of what's going on systemically. There has been some literature, particularly in diabetes, which I'm going to take as another example, since it is, we have an epidemic. It's the next tsunami that's coming with the result of some of the obesity issues that we have here in the United States. So the research is there adverse effects on diabetes and periodontal disease and perio health? And what basically the evidence shows is that there is a connection between severe periodontal disease and worsening of glycemic control. If you can control the periodontal disease, you can actually reduce glycemic control and improve somebody's diabetes. So let's talk a little bit about diabetes. We know that 25.8 million people in the United States, or 8.3%, have diabetes. But I think what's more the next tsunami, as I talked about, is that the undiagnosed is 7 million and the pre-diabetes is 79 million. And 1 in 3 Americans by the year 2050 will have diabetes. There's a huge economic cost to diabetes, so really the initiative is to start screening people in the pre-diabetic phase, because you can actually slow or reduce the onset of diabetes. When we look at the prevalence over the last decade, we're losing the battle on all age groups, but particularly on the elderly, the seniors who are 65 years and older. So who is at risk and who should be screened? Anyone who is age 45 or older should be screened for diabetes. Ethnic minorities such as African American, Hispanic, Asian American, Pacific Islanders, and American Indian are more at risk for diabetes. If you've got a parent or a brother or a sister with diabetes, that puts you at a higher risk. If you are obese and more physically inactive, that also is a risk factor. Anyone whose blood pressure is greater than 140/90 should be screened or is at risk. And low HDL, the healthy component of the cholesterol, the high density lipoprotein cholesterol, or if there's a high triglyceride greater than 150. Anyone gestational diabetes or with a baby that weighed more than 9 pounds is at risk. And then somebody with polycystic ovarian syndrome. We know it's the 6th leading cause of death, and that when people have diabetes, they're at twice the risk of having a stroke or a heart attack. And in fact, we are much more aggressive with where their blood pressure and cholesterol goals should be, because we see them as if they've had, if they've got the same risk as someone who has coronary artery disease. Unfortunately, the complications of diabetes are blindness, amputation, renal failure, and we're seeing a lot more renal dialysis, vascular disease, peripheral neuropathy, high blood pressure, and strokes. So all of these things can be reduced if we're screening for diabetes better. Some of the other complications are at risk for falling, dehydration or mental changes as the sugar may be too high, and then some of the chronic complications. Often it's suboptimal treatment and management can cause some of the mental illnesses. Having a chronic illness and depression, we know, is bidirectional. One can actually exacerbate the other. Which came first, it doesn't matter, but if you can treat the depression, you'll actually improve the diabetes and vice versa. Here's the new criteria that just came out last year on diagnosing, and really the use of the hemoglobin A1C has opened up many more patients that potentially have the pre-diabetes. So when we do the hemoglobin A1C, which is the average blood sugar over a 3-month period, the normal should be less than 5.4. So if somebody's coming up into that 5.7 to 6.4 range, they definitely have criteria for pre-diabetes. And that's where we can really hone in on these patients and improve through diet, exercise, sometimes medication, to really look at preventing, or as I said, slowing down their progression to diabetes. There is a program and evidence called the Diabetic Self-Management Education Training, and we implemented some of these to start a diabetic care and lifestyle treatment center within the College of Dentistry and Nursing. And we targeted seniors from 50 and above, because we know that 40% of older adults with diabetes, age 65 to 64, can have a reduction in their diabetes if they go to an educational program. So it's a 1% reduction in hemoglobin is associated with a 37% reduction in risk of kidney, eye, neurological complications. So knowing this data, this has helped us to implement within the College of Dentistry to screen for diabetes, try and capture the people who either have it or have pre-diabetes, educate them with a nutritional, social work, multidisciplinary approach to get that reduction. And this was an example of our pilot project. We went on to the periodontal clinics, and we looked at screening using the ADA screening tool for diabetes to try and highlight and see if there really was a connection between periodontal disease and their risk for diabetes. So Veronica was a 72-year-old Caucasian female. She was at the periodontal clinic and obviously had a history of periodontal disease, which they classified, and there is a way the dentists classify it, as moderate to severe. She also had a history of depression, no diabetes or heart disease or high cholesterol. She takes Zoloft for her depression. There is no family history, except her mother has hypertension and depression, but no family history of diabetes. She lives with her husband and 3 children. She exercises twice a week, and she doesn't smoke, and there's no alcohol. So this is the risk assessment tool for diabetes that we use, based on the criteria that we had addressed before on who's at risk. She had 2 risk factors that you can see. She doesn't have any daily exercise, and she's over 45. Then the other part of the tool is the symptom tool. Does she have blurred vision, fatigue, extreme thirst, frequent trips to the bathroom? These are some signs of uncontrolled diabetes. Unexplained weight loss, slow healing of wounds and cuts, numbness, frequent infections, and depression. So she had 3. So overall she had 5 positive, which means that she is at risk for diabetes and should be screened. We did her hemoglobin A1C, and even though she had not sort of the classic symptoms of diabetes, using this tool, her hemoglobin A1C gave her a diagnosis of diabetes. So here is an example of, we know periodontal disease puts people at risk. Her blood sugar was elevated, she met criteria for diabetes, and she never knew that she had diabetes. And as we know, it takes about 5 years before someone gets to a diagnosis. So if we can intervene within that 5 years, just think of all the long-term complications that potentially we can reduce. We made a referral to our diabetic care and lifestyle treatment center where she got counseling, and we also picked her up as a primary care patient. So this was some of our pilot project outcome data. So after 5 days of screening patients in the periodontal clinic, the average age was 52 to 82. We screened 41 patients who had moderate to severe periodontal disease, and the range for hemoglobin A1C was 4.7 to 7.2. Now remember, these are patients who had no idea that they were diabetic. So 26 of them were pre-diabetic, 2 were diabetic, and we made 23 referrals. So as you can see, our question is, does diabetes and periodontal disease share common pathophysiology, including inflammation, altered host response, and insulin resistance? Absolutely. As you can see, we know that there's risk factors when you have diabetes, that your patients should go off and see dental because there's a risk for gingivitis and periodontitis. We know that the relationship is bidirectional, and as I said, one will make the other worse, and both are treatable. So if you improve glycemic control, you will actually improve diabetes and their periodontal disease. The next case I want to share with you, just to highlight our collaboration, is Ben. He's a 42-year-old African-American man who came to the College of Dentistry for routine dental assessment. The dental student takes, and every student takes, their blood pressure, and that's often a barrier to continuing on with their dental care. So you can see that at a blood pressure of 185 over 105, the students were unable to continue to proceed without addressing his blood pressure first. He also was noted to have severe periodontitis. He was referred down to our practice with a medical consultation form. He tells us that he's had no primary care intervention for 15 years. He does have a family history of diabetes. He has 10 beers a night and didn't really think that was a problem. He was obese, but he had frequent urination, and he smoked marijuana every night. So what did we do? We did a full physical and assessed a cardiovascular assessment. We did a random blood sugar and a hemoglobin A1C. We looked at his EKGs. We looked at his lab work to look at his kidney and renal function and liver function, his lipids, his thyroid. And we talked to him about smoking cessation, obviously, and addressed his alcohol abuse. And just like with smoking cessation, our alcohol approach is not just do you drink, tick a box, yes, but actually, again, almost using that 5A assessment to help him to recognize that 10 beers a day is a problem. These days, it's a little more controversial with the prostate surface antigen and digital rectal exam, but we discussed that with him. So his labs came back. His random sugar was 521. With a hemoglobin A1C of 11.7. And really talking to him, this man was quite miserable. There was a lot of depression. He was closing down a bar at night, didn't want to go home. But he also wasn't sleeping. He was getting up frequently during the night, almost every hour to 2 hours because of frequent urination. He also was quite excoriated from having tinea curis, from having high sugars coming out into his skin. So we were really able to do a lot for this gentleman. We started him on antihypertensive medications. We started to talk to him about his diabetes, started him on Lantus, and we were able to continue his dental care and help him reduce his alcohol and to stop. So here you can see that periodontal therapy aimed at eliminating infection and reducing inflammation can improve diabetes control, as I've said. And so Ben, even if the dentist hadn't recognized his blood pressure just purely with the periodontal disease, it's so powerful to be able to say, maybe this person should be screened for diabetes. My next example of how we can collaborate on oral systemic illnesses is a 58-year-old Alexander, a Russian gentleman, who was seen at oral medicine for a 3-month history of very painful oral erosions. And he'd had fatigue and weight loss with this. He had difficulty swallowing because of the pain and had put down his weight loss because of that. They had sent him to us because they were unable to do a biopsy of the oral mucosa because it was so fragile, and wanted us to work him up for some blood tests, plus he had never seen any primary care for a long time. And this is a picture of what the lesions look like. So you can sort of think about what would maybe some of your I haven't told you what the diagnosis is yet, but if you wanted to take a guess at if you were in primary care and looking at this mouth, what would you be thinking about? So he actually had pemphigus, which was why oral medicine referred him to us, and there is a blood test for antibodies that we did for him. And pemphigus is a rare disorder that we actually do see quite a lot at the College of Dentistry, and it's caused by an autoimmune response to a specific portion of the demoxylin 3. It's a protein that's found in normal healthy skin in the oral mucosa, and this does result in painful erosions on the face, body, or oral cavity, which, if led, can lead even to death. These days, with oral steroids and autoimmune medications such as Imuran, it can be successfully treated. So what else did we do for him? We did the lab test to help with the diagnosis, but we then wanted to work up his weight loss. As you know, 58-year-old male with significant weight loss should be colon cancer until proven otherwise. So we referred him for a colonoscopy, as well as he had an upper endoscopy. We referred him to the skin center because pemphigus can also come out with skin lesions, which he did actually have one on his back that was positive for pemphigus. And then because he was starting steroids, we could monitor his bone density, his blood sugar, because steroids put you at risk for diabetes, or elevated blood sugar at least, and some potential mental psychosis in much higher doses. Pain management, because obviously the man could not eat due to pain, and then really looked at his age-appropriate cancer screenings as well. So on that note, I hope today that I have highlighted to you the importance of collaboration, the importance of when you're looking at somebody's mouth, that you're actually really, it is a reflection of what can be going on systemically. And that often systemically, for the nurse practitioners, don't forget there is a mouth, and the mouth can really tell you an awful lot. As I had said earlier on, this is the social ecological model, which really recognizes that there is an interwoven relationship that exists between the individual and their environment. That really individual behavior is determined to a large extent by their social environment. So when you're looking at barriers to healthy behavior, what is shared to the individual is often shared by their community. And to affect change at the individual level, just if you take smoking for example, it's really looking at policy changes, what's going on at home, what's going on with their culture. So you can't just think of the person as an individual. I also just think of this model sometimes as, if we looked at just being an island within our own community or a silo, and practicing the patient within the silo, then we're not going to achieve change and achieve benefits for the patient. That actually, if we work collaboratively with our colleagues at policy level in the community and together, then we can promote certainly healthier changes, not for the individual but for the community at large. So on that note, I thank you for your time. And please note the references on each page. And finally, congratulations on completing this module. And if you need additional online modules, please visit the www.hartford.ign.org/education/CNYGEC, or you can also visit www.cnycec.org. And I would like to just thank the CNYCEC for this opportunity, and the Hartford Center as well. Thank you.